afternoon, I guess it is, isn't it? Everybody, welcome. Okay, sure. Yes, Representative Ballard.
Thank you, Mr. Chairman. For those of you that are here, I want to introduce my intern to you. She's with us, and then she has a meeting at the Speaker Pro Tem's office at 4. Emily Depew, would you stand? She's a second-year law school at University of Kansas.
Very good. Thank you for being here. I'm kind of sorry you have to put up with Representative Ballard, but just joking, honestly.
And she's my friend, too.
Yeah. In this day and age, I want to make very sure that that was a joke. No. So anyway, with that, Director Fertig, are you on board? Oh, I'm sorry. I am so glad to see. Well, you know, it's been a rough year, so.
There we go.
Anyway, well, very good. Thank you for being here. And Director Fertig is a medical director for KDHE. Well, I'll let you introduce yourself, of course. And she's going to talk to us about the recommendations from the Child Care Oversight Committee, which is a joint committee of Senate and House members. Representative Ballard sits on it, and we meet quarterly. And we have testimony from folks all over the country about issues. So anyway, very good. Thank you for being here, and we look forward to hearing what.
Thank you, Mr. Chairman, and good afternoon, committee. So Chairman Carpenter told you a little bit about the Child Care Oversight Committee, also known as the Bob Bethel Committee. I feel like I am just bellowing into this. There we go. Also known as the Bob Bethel Committee, and it's tasked with overseeing Child Care generally. So the Kansas Medicaid program, the 3 managed care contractors that the state contracts with to deliver managed care to Medicaid beneficiaries, and it's also tasked with overseeing home and community-based services. So these are largely programs for elderly and disabled Kansans who are on Medicaid, and it allows them to receive additional services that can help them live in the community rather than being placed in an institutional placement like a nursing home. So that's kind of what the Bob Bethel Committee discusses. And we had a very active session, particularly in the interim. There were a lot of really good discussions. And I believe the recommendations are still somewhat tentative because I don't think the committee has voted on them yet. But there were a lot of good topics that came out of those discussions. So one of the ones that we talked about related to adding a particular code to the list of codes that Medicaid covers. So those of you who are familiar with the way medical codes are billed, there's a whole series of them, CPT codes. So if you're familiar with this at all, this will ring a bell. And so there's been a push for a couple of years now by largely mental health advocates for Medicaid to start covering a code. It's number 90846. It's one of the few CPT codes that I actually have memorized in terms of what it is, because that's how often we discuss it. And it's for family therapy without the patient present. And if, like me, you are confused by that description, it comes about, an example where that might be used is if you have a foster family and they take their foster child in for therapy. And the therapist determines that they really need to speak with the parent, the foster parents, outside the child's earshot to talk about structure in the home or what the parents need to do to help advance the child's treatment. That's when that code would come into play. And currently in Medicaid, we don't cover that code. So if a provider offers that service, they can't bill Medicaid for it. So there's been a lot of pressure, good pressure actually, for the state to start covering that code. And after doing some research, KDHE and KDADS agreed, and we're in the process of gaining CMS approval to cover that code. KDADS is working on a policy that will tell the MCOs how to pay providers for that code. So that's definitely in process. That is also a topic that was discussed by the Mental Health Modernization and Reform Committee, and it came out as a recommendation of that committee as well. So we were pleased to see that the Bob Bethel Committee appears to agree with that direction because we think it's a good place to go as well. Another big topic that we talked about, and hopefully we'll talk about this more in the coming session, is the prospect of adding 10 months more Medicaid coverage to pregnant women in the postpartum period. So this is a topic that has been discussed a lot by states across the country, really for the past year, but it kind of reached a peak when the American Rescue Plan Act was passed in March of 2021, because that law created a new streamlined opportunity for states to extend coverage for postpartum women through a simple Medicaid state plan amendment. And for those of you who are not super familiar with the mechanics and the weeds of how Medicaid works, a state plan amendment is the easiest possible way to effectuate a change to your Medicaid program. It's a lot more complicated if you have to ask for a formal waiver of requirements, that type of thing. So for the first time, CMS was going to let states, through a simple state plan amendment, extend coverage for postpartum women. Now, the policy change that would entail, right now, women who are in our pregnant women eligibility group, their Medicaid coverage terminates about 2 months postpartum. And so, from a personal standpoint, I can tell you that 2 months postpartum, you are not 100% back to yourself. And so the idea is that instead of cutting off coverage at 2 months postpartum, for the women in the pregnant women eligibility group, we would extend their coverage through a year postpartum. So right now under Medicaid, a baby born to a mom who's on Medicaid automatically gets 1 year of eligibility through his or her first year of life. The idea with extending postpartum coverage is that we would then match mom to the baby's first year of coverage. And that would allow mom to continue getting treatment, behavioral health treatment, if she suffers some type of delayed medical issue from the delivery that hits her, more than 60 days postpartum, it would give her coverage to get that addressed. So there are a lot of states that are looking into that. Most recently, Georgia and South Carolina joined the ranks, and so Kansas is one of virtually every state that's looking into adding this to their program. So we talked about that quite a bit during the Bob Bethel Committee, and the state, we asked our actuaries to come up with a fiscal estimate of what that would cost. It's about $10.5 million, all funds. And I know there was a question at the last Bethel Committee, Mr. Chairman. I believe Senator Gossage had asked how many women that would impact. Typically, in an average year, we have just under 15,000 women who are in the pregnant women eligibility group at one point during the year. So if you have your baby in December, you'll be in the pregnant women eligibility group in January and February of the following year. So about 15,000 individuals fall into that eligibility group in any given year. So those are the folks that we're really talking about. And our fiscal estimate on that is about $10.5 million. This is something that we asked for the governor's approval in, and so that we were pleased to see that made it into her budget recommendation this year. So we're hoping to kind of continue discussions with the budget committees, and hopefully that's a policy change that we could shift. Mr. Chairman, if you like, I can pause here in case anyone has any questions so far.
Committee questions so far.
Chairman, thank you. Representative Dr. Clifford, who is Bob Bethel? I don't know why the committee's named after an individual. Can you tell me who that is or was? Anybody know?
Representative Ballard.
Thank you. Bob Bethel was a legislator here, and we were on appropriations together at Social Services. At one point, he was the chair of the Social Services budget. And oh my goodness, I guess I'd have to go back to about 15 years ago now. I mean, time goes so quickly. We finished on a Sunday around 2:30, and we adjourned. No, it was 2:30 in the afternoon. And we adjourned, and he packed up from the hotel and he left to go home, and had an accident, and we don't know exactly what caused it, but he was killed on his way home. But a lot as a result of that, we named the committee, because he had spent so much time and dedication to it, the Bob Bethel. And then the rest was the Care that took effect in 2013. Okay. And he was my dear friend, so actually I got through it and I didn't get emotional. Thank you.
And as you dig through regulations and statutes and stuff like that, his name is on a lot of stuff. So he's very, very active. So thank you very much. Any further questions?
On the postpartum, the coverage of 10 months, so it'd be 12 months total, is there a medical reason for that, or is it just to match the baby and just kind of keep it coverage?
That's a really great question. And Mr. Chairman, there is a medical reason for that. Our public health division, they're the experts. They have a maternal and child health division, but essentially there's a benefit to mom, obviously, that if you have continued coverage, you're more likely to seek behavioral health treatment, for instance, if that's something that you might need. We had a study conducted by the Kansas Foundation for Medical Care, and just by way of example, they found that about a third of Medicaid moms have a behavioral health diagnosis at the time of delivery, and about 25% of them have a new behavioral health diagnosis more than 60 days after delivery. And that could be anything from postpartum depression, substance use disorder, depression, anxiety, what have you. But there's also been studies that have shown that if mom is insured, baby is more likely to make it to timely new baby checkups, because that first year they're always in a doctor's office for a checkup. And if mom is insured, baby is more likely to make it to those appointments on time and get that care when they're supposed to get it. So that's kind of part of the theory behind it, but it also, it benefits mom as well as baby. It's a kind of a two for one benefit there.
So maybe nothing physical, but more the mental. Okay.
Sure. I mean, not
On that.
Sure, not everybody, Mr. Chairman, not everybody's going to have, a rocky postpartum period. I was lucky I didn't sustain any serious medical issues that I had to go back and be hospitalized for, but that's always a possibility. You never quite know how it's going to go. But yeah, that's kind of the thinking, that there is science that indicates that the outcomes are better for moms if they have that coverage, but also that outcomes are better for baby as well if mom is covered.
And this just goes further into the fact that pregnant women are presumed eligible, and that they do have, if they qualify for Medicaid, they are covered by Medicaid, to encourage them to have regular doctor's appointments and all that kind of stuff. So this just feeds into that. Thank you. Further questions? Okay, continue on. Thank you.
Sure, Mr. Chairman. And actually, I'm recalling actually at the September Bob Bethel meeting, there was a presentation by the MCOs on the work that they do with pregnant women. And Representative Reeves, you might remember this as well, but they were talking about the wraparound services that they provide after mom gives birth. And if you have somebody who, they can't do that if they're not a Care member. So if you have somebody who really needs assistance at 70 days postpartum, they might, Aetna might not be able to do anything for them because they're no longer a member for them. So I'm recalling that as well, that that's also a limitation for the aftercare services that the MCOs provide. All right, so another topic that was discussed during Bob Bethel related to Medicaid provider reimbursement. So as legislators, if you get a call about Medicaid, it's not surprising if you get a call from a provider, what they're talking about is their reimbursement rate, and more specifically, they would like to get paid more for the services that they provide to Medicaid beneficiaries. And so we heard from a couple of key constituencies and key provider groups with their requests for Medicaid provider rates. And at the December Care Oversight Bethel Committee, we heard from ambulance services. The number of ambulance services came out and they were talking about their Medicaid reimbursement rates in relation to Medicare. And they're quite low in relation to Medicare. And just by way of example, the Medicare rate per mile for an ambulance is $11.55. The Medicaid rate per mile for an ambulance is $3. So it's quite a bit lower than Medicare. And that's after a 50-cent per mile increase that went into effect in 2018. So for a long time, it was $2.50 a mile. So they came to the Bob Bethel Committee to try and make a case for increasing some of their rates. And so one of the topics that was discussed is basically what should the legislature do in that regard? What could we look at in terms of trying to boost those rates, index them to Medicare in some particular way? And so, we had a discussion, and I think my team is going to be working to put together some numbers that we can kind of see what that would look like. If we boosted ambulance rates to, say, 65% of Medicare, 75%, what have you, what would the cost be in terms of state general funds, all funds, and the like? So that's something that our team is working on. Another particular topic related to Medicaid reimbursement rates related to pediatric primary care. So pediatricians are kind of, the first line of defense for a lot of our most vulnerable kiddos. And some of the reimbursement rates we have for them are also quite low. And they've not seen a significant increase since the mid-90s. So we're going on, well over a decade of stagnant reimbursement rates for pediatricians. So that was one of the topics that we talked about as well. And that's another area that our team is researching to kind of figure out, of those primary care codes, what would it cost to increase those rates to a particular percentage of Medicare. And I'll pause here for a moment, Mr. Chairman, and just talk a little bit about that. So a little bit of background. Those of you who are on the Bob Bethel Committee in December, I talked a little bit about how Medicaid rates are set. And there's basically no statutory standard for how much we need to pay providers. In some states there is. They have a statute that says Medicaid shall pay 80%, 90% of Medicare, whatever the case may be. That's not the case in Kansas. And so historically, the process of increasing Medicaid reimbursement rates has been really ad hoc. So if you have a provider group that comes to the legislature and they succeed in getting an appropriation, then we'll increase rates for that provider group. That happened a couple years ago with dental rates. There was a $3 million appropriation, so we went ahead and increased those rates. But typically, there's no uniform process for periodically reviewing and updating Medicaid reimbursement rates. And so as a result, based on my research, there are a lot of rates that haven't budged since the 80s. I mean, even back before, when I was in elementary school, is the last time some of these rates got increased. So one thing that we've been kind of studying to try and provide some more useful information to the legislators is how long has it been since certain codes have been increased? And what would it take to bring them up to a more common level, something more acceptable to providers today? And there's been a long-standing informal benchmark that the Medicaid team uses to set rates initially, and that's 65% of Medicare. That's not written down in policy anywhere. It's not in a regulation. It's not in a statute. That's just been the practice for as long as anyone that I work with can remember. And we have folks who've worked in Medicaid since the early 90s. So it's just been the practice for years. So informally, we would set the rate at about 65% of Medicare, and then may or may not update it and increase it after that. So historically, that's kind of how it happened. The one exception to that is that for laboratory rates, we did adopt a formal policy setting those at 85% of Medicare because there's actual materials costs involved in those lab rates. And so we wanted to make sure providers at least were compensated for the cost of the product needed to conduct that lab. So that's kind of historically how it's been, and why, as legislators, you might occasionally get a call from a provider asking about your Medicaid rate and why it hasn't been increased in so long. Another group that approached the Bob Bethel Committee and was seeking some information and possibly an increase were certified nurse midwives. So most babies born in Kansas are born in a hospital setting. Some of them are born in birth centers and they're attended to by certified nurse midwives. There is a long-standing Kansas regulation, I think it was adopted in the mid-'80s, that sets the reimbursement for mid-level providers, so APRNs, certified nurse midwives, at 75% of what the physician rate is. So we sometimes call that the 25% haircut. And so there are some certified nurse midwives who feel that that's unfair, that, they're also helping to birth a baby, and they're kind of providing similar services to what a physician would in a hospital setting. Why are they subject to the 25% haircut? And so one of the things that we plan to study is what the fiscal impact would be if we were to revoke at least that part of the regulation, and take away the 25% haircut for nurse midwives and for all mid-level practitioners, just so that the legislature could have a feel for what that fiscal impact could be. Another topic that we talked about, similarly on reimbursement rates, there has been a lot of discussion over the last year or two on specialized medical care, also known as private duty nursing. So this is nurses that come to an individual's home and take care of them in a private setting. It is very commonly used with certain individuals on home and community-based services waivers. These are the special programs we have for disabled and elderly Kansans who are on Care, and particularly what's known as a technology-assisted waiver, the TA waiver. And this is for kiddos who have rather intensive medical needs, and they're reliant on technology to, sustain their well-being. So examples might be they have a trach. So these are kids, very, very complex medical conditions often, and they really rely on in-home private duty nursing to keep them healthy and safe. And until last session, the Medicaid reimbursement rate for that service is really quite low. It was $31.55 an hour. And if you've been reading the news at all, nursing salaries are getting very, very competitive in hospitals. It's really, really hard to find nursing staff. That was a challenge that existed before COVID. It's only gotten worse since. So in the 2021 session, the legislature increased the reimbursement rate for that particular service for the technology-assisted waiver to $43 an hour. Advocates pointed out they were very thankful for this, and I've heard nothing but positives about that change. But they did point out two issues with that. One of them is that there's another home and community-based services waiver that also authorizes private duty nursing, and that is the Intellectual and Developmental Disabilities waiver. And so they were left out of the rate increase. So for the IDD waiver, we're still reimbursing $31.55 an hour for that service. For the TA waiver, we're reimbursing at $43 an hour. So there's a disparity across the two programs. And then also, ideally, my understanding is that the advocates would prefer to see the hourly rate increase to about $47 an hour. So we talked about that, and I think, Mr. Chairman, I believe KDADS is working on a fiscal impact to figure out what that would cost. But I think that that's something that we would support because it just makes sense. It was a huge accomplishment to get the TA waiver rate increase last session. That was fantastic. But we really need to kind of standardize that across the waivers. And if we could bump it up even a little bit more, that would be good as well. But KDADS is working on that fiscal impact, so that's one of the many, many topics that you all will have to discuss as part of this committee.
And committee, I might add that was my mistake, quite frankly, that I didn't include the ID and the DD in our proviso. And the other thing that I didn't realize how prevalent, it's about 80-20 is what the split is on that I will do my best to correct that this year. Representative Lynn.
Thank you, Mr. Chair. We heard in committee that a lot of the providers aren't actually receiving that reimbursement rate for themselves and their salary. Is there any sort of regulation that when we provide that to the agency for the $43 an hour, that gets given to the provider?
Mr. Chair, that's a great question. I know that this was something that was discussed, I think, at the September Bethel, and I think it came up again in the December Bethel. So a couple points on that. Number one, my understanding, when we were looking into this issue maybe a year or so ago, at that time, about a quarter to 1/3 of kiddos on the technology-assisted waiver had what's known as a special case agreement with their MCO, where they agreed to pay above and beyond the Medicaid rate in order to secure those services for their members. So about 1/3 of the TA waiver kiddos had a special case agreement in place to make sure that their private duty nurse was paid more. And my understanding is that most of those special case agreements were above the $43 an hour range. So the MCOs were already paying those nurses more to try and make sure that that kiddo had continuity of care. So in some cases, I think that's what's going on. But in terms of whether or not there's a regulation that would mandate that that funding go directly to the nurse, no, there isn't. There could be something, I would be surprised, but there could be something within an MCO provider contract that would mandate that that's where that money goes. But there's nothing on the state side that would mandate that that money goes specifically to the nurse. What it did is increase the reimbursement rate. And when you're working with a staffing agency, a portion of that rate goes to administrative costs. But we don't limit how much the administrative costs are at the state level.
If I may. It just, when we heard from the different providers and the different nurses, it sounded like almost none of them were actually getting this pay increase. So I guess I hope that we can look into that further.
I think on the agenda next week, we do have a staffing, a topic about staffing and that kind of stuff, so that might be a great time to flesh this out.
And Mr. Chairman, I think some of the providers who work for staffing agencies, I think they probably have more information to share on how that actually works on the ground. But I do know that in some instances, at least, the $43 an hour was less than what their nurse was already getting paid.
Very good. Committee, further questions? Well, I might just add the T1000, that's what we call that. And the gist of the whole thing is that, and there's a lot of numbers out there, and folks that are on Bethel know that, but it's $4,000 a day to have them in the hospital, or it's $47 an hour to keep them at home. Mm-hmm. And it's kind of, and that's how simple it is. So anyway, that's my, Representative Clifford.
Thank you. And I'm an eye surgeon, so I deal with Medicaid. But I've never understood the federal reimbursement rate to the state of Kansas, fast rate or something, and why we get less than another state. You have like two minutes, if you would indulge me, because when talking about Medicaid expansion, I know some states are getting people off their Medicaid rolls and then bringing them in as an expansion state because they get a higher reimbursement. So can you clue us in on that rate or how it's derived? Thank you.
Sure, I'd be happy to. Mr. Chairman, so generally speaking, the standard federal matching that we get to pay for Medicaid medical costs is about 59% federal. So in a normal year, about 41% of the money we pay to the managed care organizations is state general funds and 59% is federal. We're under a special rule right now due to some pandemic legislation that passed in March of 2020 that increases the percentage of federal funding that we're able to draw down to pay for Medicaid by 6.2%. And that has been a tremendous financial boon to the state. The last number I saw, Representative Carpenter, I know you keep an eye on this pretty closely, but I think the last number I saw, I think through the end of July, it has been about $450 million extra coming into the state. It's been pretty huge, and that 6.2% bump will continue through the end of the quarter in which the federal public health emergency ends. So HHS Secretary Becerra just renewed the public health emergency. It's currently scheduled to end in the middle of April. That means we can continue to receive the extra 6.2% FMAP through the end of June. If nothing else changes, we've got that money through the end of June. So that's how it normally is. With expansion, it's a little bit different. For the expansion population, the federal matching percentage is 90%, and the state percent is 10. Now, there was some federal legislation that was passed in the last year that added, we refer to it internally as the sweetener of a 5% extra federal matching funds for 8 quarters for latecomer states who choose to adopt expansion. So if Kansas adopted it for 8 quarters, we would draw down 95% federal funds to pay for it, and then revert back to 90 after that 8-quarter period is over under current legislation. So that's kind of how that goes. And there are some states who, when they adopt expansion, they end up saving money on certain populations because you shift them from a population where you're drawing down 60% federal matching funds, and now you can draw down 90%. So that happened in Wisconsin. They were already covering up to 100% of the federal poverty level for Medicaid. And when they were talking about expansion, the Medicaid director basically said, hey, if you do this, it'll save me money. I can give provider increases left and right. It'll be so much cheaper to draw down 90% federal dollars to pay for that chunk of folks. And so it saved some money in Wisconsin. But it really depends on the state circumstances and how much they're already covering. But you're right, there is a significant difference in the amount of federal matching funds that you can draw down for regular Medicaid versus the expansion population.
Thank you, that's excellent.
Representative Helmer, did you have a question?
Yes, I need clarification. I have a friend that is a midwife, but she's gone on with her education. So I don't understand why so I need clarification. Midwifery, I know it started kind of as a homegrown trade, and that's still present. And then it evolved, and correct me if I'm wrong, it evolved into APRN, right? And now it's gone on further to where, well, practitioner, I guess, would be the next one. And then most of them have gone on, if they want to achieve better training and better pay, into APRNs under the assist of a physician. So they're making really good money then. And that's where my friend is. So where are we? You're saying pay grades. So that looks like to me 3 pay grades according to training and safety and education requirements. So where are we that you want, or that you're saying that we need to upgrade that?
Oh, that's a great question. And Mr. Chairman, I don't think we have a recommendation on that specifically. Representative Helmer, yeah, the issue really is, and I think for the reasons that you're bringing up, that profession has changed over the years, and there's a lot more training that goes into it, more formalized training. And I think for those reasons, that's why the nurse midwives are asking for the 25% reduction in the amount Medicaid pays them to be removed from Kansas law. So, we only pay them 75% of what we would pay a physician to deliver a baby, and they would like to see that pay differential end. And the regulation that sets that 25% reduction has been in place since the early 80s. So I think, that was probably in a very, very different time for that practice. I'm not up to date on midwifery, but yeah, we're not recommending anything in particular. It's just this was a request that came in front of the Bob Bethel Committee to get rid of that 25% reduction. So what we're going to do is study and see what that would cost if we applied that to certified nurse midwives only, or if we also applied that to all mid-level practitioners. So if an APRN delivers a service, would we no longer reduce their pay by 25%? And this is just the reimbursement rate that Medicaid would pay the facility for that service. what the facility pays their actual staff, we don't really have any control over that. But in terms of what Medicaid pays the facility for that service, that's kind of what we're studying.
Very good. Committee, further questions? Okay, very good. You on, please?
Sure. So one last thing that I wanted to address, Mr. Chairman, and then if you or Representative Ballard or Representative Ruiz wanted to remind me of any topics that you want me to bring to the attention of this committee, I'd be happy to do that. But we also we heard a lot about the difficulties that some families have in securing care for their loved ones at home. So this might be an individual who is on one of the home and community-based services waivers who has a disability and they require personal care attendant services, so someone who can help them transition from a chair to a standing position, someone who can help them bathe, get dressed, do toileting, all of those daily exercises. And, it was already challenging for some families to recruit staff for that work, even before the pandemic. And again, it's become even more challenging since the pandemic began. And one stopgap measure that the Medicaid program implemented during the pandemic, initially kind of to help stop the spread of COVID, was to allow family caregivers to get paid for caring for their loved ones. So the thinking initially was this will stop the number of out-of-the-home folks coming into the home to deliver services, and it could also help families when someone might be temporarily out of work. Well, we have heard from advocates and families who would like to see that flexibility continue even after the pandemic ends. Right now, that is a flexibility that only exists because of special rules that are in place during the pandemic. And so one topic that we discussed is whether or not the state should look into receiving CMS approval for that to become kind of built into the Medicaid program. So not just a special pandemic only accommodation, but something that we adopt more full-time. And we do understand that there would need to be some safeguards in place there. One concern that we have is that if MCOs and other outside staff aren't able to see the patient, you might not know if there's potentially abuse going on. And so talk, very conscientiously about what we would need to do to adopt that policy long term. So I think that's something that KDADS is studying, since they administer all of those disability programs, but it's something that I imagine we're going to be talking about more going forward. And Mr. Chairman, I can pause here, see if there's any questions.
Committee questions? Very good. Representative Ballard.
Thank you, Mr. Chairman. Not so much a question as how important that family caregiver is, because they assume because you're a family member you are, but for many of them, they work. And so they may do, say, an 8 to 5, get home 6 o'clock, whatever time, then at some point they have to go to bed. But that person may still need someone to monitor them over the night. And so then when do they sleep? When they have to turn around and go to work. So in that case, it's not that they don't care about their family. They love their family member, whoever it is, but they're also a breadwinner, and they have to be able to work. So when we don't provide that for them, an outside help, they were saying, well, you can do it. Well, technically you can't, because you can't do two things and then go and do a decent job and be alert at work and all of that. So that's why that was really important for us to really be clear about how we pay them and how much we do, because you can't ask them to do that as a caregiver at the same time. I mean, because they need more help. Does that make sense?
Very good. Committee, further questions? Very good. Thank you, Director Fertig. I call her Sarah sometimes.
You're allowed to, Mr. Chairman.
Official here. Well, thank you very much for the presentation. And
Thank you.
committee, you'll be seeing a lot of her this year. Unfortunately for her. No, I'm just kidding. Okay, very good. Well, thank you again. Next, we have Kelly Mark, And I think Kelly's going to be virtual.
I am here. I am virtual.
She's going to give us a presentation on the child care licensing. Okay, very good. Kelly, are you there?
I am. Can you hear me?
We can.
Okay, I'm going to share my screen. Thank you. All right. Good afternoon, Chair Carpenter and esteemed members of this committee. My name is Kelly Mark, and I'm the Interim Director of the Bureau of Family Health at the Kansas Department of Health and Environment. The KDHE Early Care and Youth Program, better known as Child Care Licensing, is positioned within the Bureau of Family Health at KDHE. I know several of you were in attendance or have viewed my presentation from the Children and Seniors Committee last week. So today I'm going to give you a brief overview of the Child Care Licensing Program, but I'm going to provide greater detail on our child care licensing regulations, our background check process, data surrounding the child care landscape in Kansas, as well as discuss barriers KDHE licensed providers and our state partners face. As you can see on this slide, the purpose of a regulated child care program is to reduce the risk of preventable harm to children while they are in out-of-home care. The purpose of the KDHE Child Care Licensing Program is to provide a basic level of protection for all children, ensuring there is a standard for health and safety for all children in care across the state. The Child Care Act, Ksa 65501, has been in effect for over 100 years. The reason this law was enacted back in 1919 was to protect children from poor environments and group settings that were putting those children's health and safety at risk. We've come a long way in the last 100 years. Most notable was the sweeping legislation in 2010 known as Lexi's Law. Lexi's Law was named after an innocent child that lost her life in a child care setting. This law has greatly impacted the health and safety of our Kansas kids. The law eliminated the category of registered family daycare homes, which were not inspected, and required the transition of the homes to licensed and inspected child care facilities. Lexi's Law required licenses to be issued with an expiration date and a valid seal or sticker. Previously, our licenses did not expire. The law established a licensing fee fund and permitted increases in annual licensing fees to support core components of the program, such as inspections. The law permitted, under certain circumstances, the permanent revocation of a license or prohibition from applying for a new license or working in another child care facility. The law required the development, through rules and regulations, additional requirements for the competent supervision of children, and additional health and safety requirements necessary for the protection of children. The law also required the development of an online information system to support families in making informed child care choices. The system may be used to view compliance history of a current or potential licensed child care provider. The passing of Lexi's Law has shown a positive impact in Kansas. Total enforcements have declined from 523 in 2010 to 73 in 2020. This leads us to believe that providers are achieving and maintaining compliance with regulation now more than ever. The most common reasons for enforcements are failure to comply with licensing requirements and a prohibited person living, working, or volunteering in a facility. The fact that all facilities are inspected prior to licensure means we are preventing licensure of facilities that do not meet foundational health and safety requirements. The total number of child care deaths declined from 12 in 2007, when the agency began tracking, to a low of 0 deaths in 2020. The total number of deaths in licensed facilities fluctuates by calendar year for many potential reasons, but the causes indicate the law, as well as health and safety training and regulations, is having a positive impact. 0 deaths have been reported from 2016 through 2020. Decades of science and research tell us that the early years are critical.
Excuse me for just a minute. Could you talk a little louder or turn your volume up for us old folks that are struggling to hear?
Sure. Sorry, I'm on
Thank
COVID-19
you.
quarantine and my voice is a little affected by my symptoms, but is that better?
That's a lot better. Thank you very much.
Great. I got closer to my microphone. All right. Decades of science and research tell us that the early years are critical to child development. Children are most likely to thrive in healthy and safe environments that provide positive interactions with nurturing adults. These children are our future. They are our future healthcare workers, teachers, social workers, and legislators. While it is critical for parents to have access to childcare now so they can continue to go to work and protect our economy, it is also critical to ensure the health and safety of our children is protected. It is critical to ensure they have access to the high quality care which impacts the trajectory of their entire lives, ensuring they are ready to enter school and go on to be productive members of society. I'd like to discuss the benefits of licensed and regulated care. The first is limited enrollment. Our current capacity ratios are determined by national best practice standards, program type, space available, and the Kansas State Fire Marshal approval. It is important to the health and safety of children in care that an appropriate amount of children are allowed for the size of the physical space and for the number of providers caring for them. Training requirements are another important aspect. Licensed providers must obtain foundational health and safety training, including initial and annual training requirements. Health and safety is a critical part of licensed care. In addition to regulations, the licensee is required to develop a safe sleep plan and share that plan with the parent or guardian, develop and post a discipline plan, develop an emergency plan, practice emergency drills, and report to the parent and guardian and KDHE any critical incidents, serious injury, or death. Inspections are also a critical part of licensed care. An initial inspection is required in order to obtain a license. If a second on-site inspection is required, if there were findings present on the first inspection, the inspection is not scheduled. Annual inspections are unannounced. Compliance inspections may be required and are unannounced. Complaint inspections are unannounced and are started within 5 days or less. Immediate investigations may be conducted based on the severity of the complaint and imminent risk to children in care. Background checks are also a very important part of licensed care. I'm going to go into a little bit more detail about our background check process now. Name-based or comprehensive background checks are required for all individuals working, residing, or volunteering in a child care facility. Background checks are very important to ensure that prohibited persons are not working in child care settings, and they are a federal requirement. Comprehensive background checks include fingerprinting, which is a paper-based manual process right now. Providers must report any person working, volunteering, or residing in a child care facility. Based on the role that a person has in that facility, KDHE will notify the provider if a name-based or comprehensive check is required. Providers must then obtain a paper fingerprint packet. Some centers keep packets on hand, and packets can also be requested from KDHE surveyors or by mail. They must bring that packet to a fingerprint location, such as a sheriff's office or police department, to get their prints taken. They mail the completed packet back to KDHE. We check those packets to ensure that it is complete, and then we send it to the KBI. The KBI ensures the prints are usable, then performs the necessary checks. Name-based checks automatically feed into our KDHE childcare licensing system, but for comprehensive checks, we must log into the KBI system to retrieve the results, manually entering them into our system. Bottlenecks sometimes occur when providers do not fully complete the packet, when the ink prints are not usable and have to be repeated, as well as things like packets traveling through the mail, fingerprint locations only being open during traditional office hours, and reduced hours of fingerprint locations due to COVID-19. Some barriers providers face are having to get printed multiple times for multiple job types. Say if someone's a child care provider as well as works in the as a teacher in a school, they'll have to be fingerprinted twice. The FBI has specific guidelines that prohibit National Criminal History Check fingerprint results from being shared for multiple purposes. Individuals have to be fingerprinted specifically for the purpose of child care. Different disciplines have different federal requirements for what is included in a comprehensive check. The Federal Office of Child Care requires that child care providers have a national FBI fingerprint criminal history check, a state criminal history check, an NCIC National Sex Offender Registry check, an in-state sex offender registry check, and an in-state abuse and neglect registry check. Those requirements may differ from what the K-12 education system requires for a teacher. Our program has launched a pilot project utilizing digital fingerprinting machines called live scan machines. We've partnered with DCF, the Department of Children and Families, using 6 of their existing live scan machines across the state. This project has shown success in reducing the amount of time the comprehensive background check takes, and we are working on expanding access to live scan machines across the state in the coming year. I'm going to talk a little bit later about how this process can be streamlined even more and the barriers this will help our program and our providers overcome. On this slide, excuse me, you can see the 4 different types of licensed programs that KDHE regulates. All of these program types operate under statutes, general regulations, and program type regulations. As I have discussed, the tightening of regulation that came with Lexi's Law has had a huge positive impact on the health and safety of our kids. Regulations exist for a very serious reason, and that reason is keeping our kids safe. That being said, the world is not static. Times change, environments change, and with that, our program and our regulations might need to change. Best practice tells us that regulations should be reviewed every 3 to 5 years. Right now, our program is involved in a comprehensive review of our regulations. We listen to our regulated community, we listen to our partners, and that is how we discern what our priorities are and what regulations need to be amended or even revoked. Right now, our priority is ratio tables and age range definitions for our home setting providers. We are suggesting amendments to the tables to increase our ratios as much as possible while still following best practice and Kansas State Fire Marshal Code. We are actively working on those amendments now. When that regulation is on its way through the formal regulation process, we will go back to our list of barriers collected from our providers and our partners and begin the review and amendment process for the next issues which have bubbled to the top. This slide shows our current child and care data. Please note that the total capacity reflected on this slide, that's for the number that facilities can serve, so the number of spots that are available, not the actual number of children that are enrolled. Day-to-day enrollment changes frequently, so actual enrollment is not tracked. Our providers do have the ability to limit their enrollment based on their personal ability to care for children and meet the needs of children in their care. While a provider may have a capacity available of 10 children, they might choose to serve only 6. We allow them to self-regulate to ensure the needs of the children are met. Also, local ordinance code limits the number of children that can serve. While it is laid out in regulation currently that a group daycare home with 2 providers can serve 12 children, local code may only allow them to serve 10. It is important to note that providers often feel pressure from their community to serve the most children their license allows. It is important to have in regulation ratios and maximum capacities that align with best practices and ensure the health and safety of our children and our providers. This slide shows childcare data by year. You can see that we have lost providers, most notably in the licensed childcare home category. Why are we seeing this trend? Well, I discussed Lexi's Law earlier and the tightening of regulations that came from that legislation. I also mentioned that providers are better equipped now to meet regulation than ever before. While we continually listen to our regulated community and work to ensure they are interpreting regulations correctly, as well as work to amend regulations or put in place policy exceptions when needed and we are able, regulations is not the reason why providers are closing and leaving the early care and education profession. Workforce studies have shown us that we have an aging workforce. In 2018, 45% of family childcare owner-operators were over the age of 50. Retirement was the top leave reason recorded by Child Care Aware of Kansas from 2017 to 2018. Wages. Workforce studies have shown us that the median wage for childcare professionals is $10.20 an hour. That was in 2019. Low wages combined with long hours and often no benefits make this profession very unattractive. The second highest leave reason reported to Child Care Aware of Kansas is accepting work unrelated to childcare. Providers are taking higher paying jobs in other fields. What do we hear from our providers and from our partners? We hear that providers are stressed and need more support from their communities and their families. COVID fatigue is real and is a burden on our providers. They're having to navigate choices on how to keep themselves and their families safe. Parents are angry if providers try to implement strict mitigation strategies, and other parents are angry if they don't. Staff is impossible to hire right now. Low wages and no benefits are a huge part of this. Programs are hesitant about raising wages using grants that they would not be able to sustain. They face under-enrollment because they cannot hire enough staff to care for their total capacity. Yet they still have fixed costs that cannot be passed on to families. I'm going to talk about some ways we can overcome some of these barriers in the next few slides. When we think about the barriers that providers are facing and larger systemic issues that early care and education system is facing, it's important to note that the KDHE Child Care Licensing Program is only one piece of this larger puzzle. A large part of our program is funded through the Department of Children and Families using Child Care Development block grant funds. We fulfill the health and safety requirement of the DCF Child Care State Plan. KDHE, DCF, the Kansas Department of Education, the Children's Cabinet, as well as early care and education professional organizations and early care and education professionals are all working together to improve the child care system in Kansas. Other important players in this issue is our business community, economic development, the KBI, and the Kansas State Fire Marshal, the public, and really all of us. We are all affected by the early care and education system in Kansas. As I mentioned before, our children are our future. So where do we go from here? Just some of the supports KDHE and our partners have in place or are working actively to put in place with partners include impact grants for current child care providers to help ensure they can provide safe places for children in care, startup grants for new child care providers to ensure they have all the supports they need to open new child care facilities or in-home care. Our licensed providers have access to an ongoing system of support that includes our child care licensing surveyors and our state program staff. Also, we have developed a child care health consultant network that allows providers to connect with one-on-one technical assistance for anything from grants to business supports to training and development. We are working on developing a workforce registry and a formal career pathway for early care and education professionals. We are working on media campaigns to help the public and our business community realize that early care and education professionals are indeed professionals. They are not just babysitters. They are dedicated to their craft. They take pride in their work, and they're highly trained individuals. Those of you that were present for the Children and Seniors Committee last Wednesday heard from one of our passionate providers, Emily Barnes. Her testimony was very impactful in showing the stress providers have faced, but their unwavering commitment to providing safe and quality care. Grants and support and technical assistance can only do so much. There are systemic issues that we as a state can tackle. We can open the child care tax credit to make that credit available to a much larger range of businesses, not just C corporations. I talked earlier about how we are working on streamlining the background check process using live scan digital fingerprinting machines and other enhancements. More work is still needed in this area. Our state staff is strained by having to manually enter all comprehensive background check results from the KBI system into our KDHE system. Some possible one-time investments for ARPA dollars might be system enhancements to allow less manual entry into the KDHE system, enhancements to create online fingerprinting waivers, and possibly the purchase of more live scan machines that could be placed in non-traditional settings across the state to ensure easy access to all providers at non-traditional hours. Then there is the wage issue. We need to ensure that our providers can earn a livable wage for providing this critically important service. Other states have tackled this issue with models such as the Wages Plus program. A program such as this would work in tandem with a workforce registry and a formal career pathway. The career pathway gives our providers a clear path of advancement in their careers. Those that are enrolled in the workforce registry can see where they fall on the pathway and what they need to do to achieve advancement. Those enrolled in the workforce registry could enroll in a Wages Plus program that would, very high level, offset providers' operating costs to allow them to pay their staff a livable wage. These models are funded in various ways in different states. North Carolina is a strong example of a program like this in practice. That is all I have to present to you today. Thank you so much for allowing me the opportunity, and I will stand for any questions that you have.
Very good, Kelly. Thank you. Thank you for being here. Committee questions. Representative Ballard, and then Representative Reed.
Thank you, Mr. Chairman. You know, because of COVID, we have read or heard that we have fewer child care facilities available. We know that nationwide, over 2 million women left the workforce for lots of reasons. But how are we doing in Kansas in terms of licensed child care facilities? Do we have enough, or do we have fewer people asking to be licensed?
As you saw from that slide, the trend has been going down. We have lost providers. We do need more providers. Last check of the data as far as temporary closures for COVID-19, we had about 280 providers that were temporarily closed and had not reopened. But we are losing providers, and we do need more providers to meet the need. That's why we're trying to tackle these large issues such as livable wages, health insurance, supports for our providers, so we can increase that recruitment and retention of providers.
Do you think if we, I'm trying to think how to answer this question. I know part of the answer. Increasing the wages would be helpful, but is there a larger problem because of the facilities? In many cases, they're smaller. We licensed them to where they were, but now we're requiring more space and less, children. So, I mean, what can we do about that situation?
So really, as I said, we allow our providers to self-regulate. So while we do have ratios in regulation that say how many children they can have, they can choose to serve less children if that is what they feel they're able to handle. It is important not to have ratios so high that they don't have the physical space to care for those children, that it exceeds the Kansas State Fire Marshal Code for the actual number of people you can have in a physical space. Really, for those smaller providers, the business model just does not work. They do not make a high enough wage to be able to sustain themselves, care for their families, provide health insurance. It's just a business model that doesn't work. So we try to give them all the support that we can with grants and things that aren't sustainable, especially now when they're really stressed due to COVID. But it's really that larger issue. Well, we need to find some way to fix that business model to help those small providers stay in business. You can see from the child care data slide that bigger child care centers, those numbers haven't dropped over the last 5 years. In fact, they've stayed the same or even increased a few. They have a better model, but still they're facing real issues as far as it being impossible to hire staff because they're not able to pay what a person can get paid at Target or in the food service industry. Even those industries are able to pay higher wages than childcare is able to pay right now. And we can't pass that buck onto our families. Our families can't afford to pay more for childcare either.
Thank you so much. You answered my other question too about the larger ones that we're managing to still be okay in terms of their numbers. But thank you so much for your presentation. I think it highlighted some of the real problems that we're having, that even if we want to strengthen our workforce, we have a problem, especially with women being able to go back to the workforce if you can't find the child care. And I
Exactly.
think, and sometimes we see one thing, but we don't see the other. But I think you highlighted it quite well, and I thank you so much for your presentation today.
Thank
Representative
you.
Ruiz.
Thank you, Mr. Chair. One thing I wanted to just mention is the last page that was on the screen didn't match mine. I don't know if it matched anybody else's. But there were some things there about technical assistance and then career pathway under the recruit and retain current providers. It's not in mine. It was kind of.
I think there
it
was a
important.
last minute change to that
Yeah,
slide.
Yeah, that's it. If we could get that page, the updated page.
Certainly.
And if you could say more about the career pathway?
Sure. So a career pathway is really something that sets steps for early care and education providers. So the pathway that we're looking at in Kansas that we're developing with our partners goes from like an early care and education professional 1 up to, say, a step 8. And each one of those steps has certain requirements that they must meet. So a step 1 starts with our current licensing, what we require for licensing. So age 18, a high school diploma, a child care provider orientation, and essential health and safety training. That would be step 1. You would move to step 2 by increasing your education or increasing your experience in the child care setting, mentorship, college credit, things like that. So we would hope that one day that career pathway would be matched with wages. So if you are an ECE 1, the livable wage for that might be $15 an hour. If you are able to advance to an ECE 3 by advancing your education, getting mentored, having more experience in the child care setting, you could advance your wages. You'd be able to see exactly what step you needed to reach to get to the salary that you wanted to reach and what education and experience were required for those steps.
Very good. Representative Howerton. Oh, I'm sorry. Representative Clifford.
Ms. Marks, Dr. Clifford from Finney County, and I don't want you to take my remarks as adversarial in any way, but constructive. I'm a former county commissioner in Finney County, Kansas. The perception from the frontier, and I represent counties on the Colorado border as well, is that some of Lexi's laws put grandma out of business. And I admire the zero statistic of child loss for the last 5 years. However, one way to end traffic deaths is to have no one driving. So I'm always concerned about unintended consequences of our state government action. So I do appreciate that you're trying to speed up certification and help our folks with education. In our county, where we have huge workforce issues, parents can probably pay about $165 a week for a child. And I often wonder if states, government agencies look at what their financial impact is on those they oversee. So I'd ask you to consider that number. One of our experiences in Finney County has been a 4-year quest to certify a daycare at the Nazarene Church, a robust local network of many stakeholders, a industrial supporter, nationally known, Tyson Foods, and 4-year trial. One of the delays was due to lack of coordination or consistency between the state fire marshal and KDHE, probably before your watch. But I would ask you to ensure the education of your inspectors, because part of our problem in Finney County was a very inconsistent inspector from Dodge City, who probably is no longer in your employ. So I think some training could be done for the state inspectors. So I do look forward to working with you. This is a huge economic development issue for us on the frontier and in rural Kansas. And it's being a father of 6. I appreciate your efforts to protect children. Thank you.
Thank you very much, Representative Clifford. If I may, Chair, I'd like to respond.
Sure.
Great, thank you. Well, first I wanted to talk about putting grandma out of business. So a slide that I did not include is the types of care that do not need to be licensed in Kansas. And if a child is cared for in the home of a relative, they don't have to be licensed. If neighbors and friends put together an agreement where they trade care back and forth, that doesn't have to be licensed in Kansas. If someone is caring for a child, 2 children, or a child less than 20 hours a week, that does not have to be licensed in Kansas. So I can definitely get to you all the rules around who doesn't have to be licensed, because that was a slide that I took out to try to shorten this presentation. As far as the fire marshal, the Kansas State Fire Marshal, it would be great if they could have a dedicated child care FTE within the fire marshal's office to just do inspections for child care. That is a bottleneck that we face, is staffing shortages at the Kansas State Fire Marshal's office. And specific to the Finney County, the center you were trying to open in the church, actually myself and our field supervisor just had a conversation, a one-on-one conversation with some folks in Finney County that were working on opening that facility. And we really talked about the issues that were happening and the surveys that had taken place, and really worked to overcome some of those barriers. So that's what we really like to do when we hear of issues from you all with your constituents, is we really like to set up those one-on-one conversations to ensure that regulations are being interpreted correctly. If there's anything that we can do to help overcome barriers communities are facing, if we can figure out if it is the fire marshal that's backed up, or if it is city code, because there's also city fire code that has to be adhered to as well. So we just really like to work one-on-one with folks. It's important to us. We know it's important to you guys to get these facilities open and be able to help your families out so they can go to work. So I appreciate the comments greatly. Thank you.
Thank you, Mr. Chairman. Thank you, Ms. Marks.
Very good. Could you get us out the rest of those slides for that? I think that would be very helpful. And I appreciate we had a conversation about this, and I explained to her exactly. We're looking at knocking down dominoes that are unnecessary and streamlining the process and trying to. So that's what this committee, you guys are the eyes and ears out there and those kind of things. So if we do have issues and we do have things, we can bring them to light, flesh them out, and see what we can do to streamline the process. So Kelly, thank you again for being here, and we appreciate it. Thank you. Oh,
Thank you so much.
Representative Howerton.
Sir, I just received a call this morning from a constituent who is doing foster care for her grandchild. So the grandchild is in state care. It was with a foster family and was just placed with grandparents. And their child care facility was not paid through the foster family, I'm trying to understand this. When the baby was transferred to grandparents, there was a bill of like $3,500 that was due, and so they refused to take the same child that was in their facility because it was in different care. So now they are trying to find a different child care facility, and I'm from Wichita. She cannot find anybody that's taking new kids, I guess. Is there a list? Is there a central database? I'm assuming that St. Francis or DCF will help her find childcare, but her husband's going to have to leave his job, or she is, because they can't find childcare.
There is a resource for that family, and that's Child Care Aware of Kansas. They have a list of all licensed child care facilities in the state. There's a link on our website to get to them. I am thinking, from the way you're describing this problem, that perhaps it's a DCF subsidy issue. There's some providers that are accepting DCF subsidy. And DCF has a list of, well, Child Care Aware does too, of all of the providers that accept DCF subsidy.
So is that a problem? Not accepting the subsidies for foster children?
Oh, that would be a question for DCF. That's not something
Okay.
I'm prepared to
So not
answer.
subsidy childcare. Okay.
Very good, committee. Further questions? Representative Helmer.
Thank you, Mr. Chair. I was just going to put some bring it to, I'm caught me off guard. Representative Clifford kind of did it for me. I was shopping for, and this is, I don't mean to be funny, but it's really realistic. I was shopping for somebody to take care of my dogs, and they wanted $40 for a dog, and so I was really shocked. And I said, $40 to take care of a dog? And I said, that's more than a child. And they said, oh, no, ma'am, we charge $60 for a child. So that's just, I don't know, really. I had no idea the going rate for a child, but they were taking care of children also. So I was, this has just really brought me, it's these poor people. And I'm sitting here, yeah, thank you so much for your presentation. I really appreciated it. Thank you. Thank you, Mr. Chairman.
Committee, further questions? Okay, Kelly, thank you again for being here, and send us out the rest of those slides. And if you could send Representative Howerton that link. I got it. Oh, you got it? Okay, very good. So, committee, further questions? Megan, did you want to discuss these performance measures very quickly? Just to, there'll be a test on these giant books here when we do this next week.
I didn't want anyone to get bored tonight. So the notebooks have the performance-based budget template for each of the agencies. This was an initiative on the legislature's part to ask the agencies to provide some performance measures. This is something that they've been doing all along, and this is a way of them communicating this to all of you so you can see them and ask questions about them. On Thursday, we're going to have DCF, KDADS, and KDHE all in the committee to walk you through some of their performance measures and give you a chance to ask questions about them.
Very good. Representative Ballard.
This is pretty cool. I mean, this is really nice. I mean, you probably would think this is something new to us too, in terms of what they did. And I think they did a fine job. And I had just glanced at it when you looked at it, and you can almost look right away and see what you want to. So whoever did this, tell them that this is nice. And I haven't even perused it more. Thank you.
And committee, this is kind of trying to help us prioritize, is that the right word? Whatever. Look at what we do as a main function, and then, you know, kind of like what we do at our houses, we take care of priorities first, and then, and so that this is kind of to address that and make the budgeting process maybe a little easier, that we actually can see the priorities. So. Very good. Further questions, committee? Well, thank you very much, and we are adjourned.